Hi, my name is Gunther Hofbauer. I'm a dermatologist practicing at the University Hospital in Zurich in Switzerland. And my main interest is non-melanoma skin cancer. That means the field of actinic keratosis, squamous cell carcinoma, and basal cell carcinoma. A field-based treatment is important because in reality people come not only for one lesion but for a series of events to us. Typically a patient comes and he has one instance of skin cancer and he believes maybe taking care of that will take care of everything, but he may find himself coming back in the years to come several times with other instances of skin cancer. So we have learned in the past that it's a very good idea not only to treat one single skin cancer and take care of it, but also to take into consideration that our patients usually have large areas of sun-damaged skin. Sun-damaged skin can be seen on the face, on the forehead, on the balding scalp, on the ears, on the neck, on the décolleté, on the backs of the hands. So we have it basically all over where the sun meets our skin every day. We have learned that treating the field efficiently helps our patients and probably prevents the occurrence of future events of skin cancer that would then have to be excised, and we would be happy to avoid that in the future. Typically, people come with a set expectation that they have one problem of skin cancer that can be fixed, like in a body shop for the car, and then off they go and everything is okay again. That is partially true. You can fix skin cancer by, for example, taking it out by the surgeon. But on the other hand, people tend to come back because, like with a car that tends to get a little bit rusty maybe or worn with age, there are repeat instances of something that needs fixing. So we try to teach our patients that first of all they should protect themselves from the sun on a regular basis in order to avoid further damage to the field of skin already damaged. We try to teach our patients to recognize early changes of skin cancer arising in the field of the face, the balding forehead, the scalp, and other areas of the skin exposed to the sun. And we try to teach them to treat early on because we believe that early on we can treat efficiently actinic keratosis, for example, in large numbers, and we can resolve these without leaving scars. We believe that treating the field is a very efficient way to take care of a large number of changes in one time and to reach a very good cosmetic outcome at the same time. Cosmetic outcome nowadays is very important. People want to look pristine. They want to look like they did before. They are not fascinated to have scars on their face, for example. The answer to that problem is to treat early. If we treat early, if we have lesions that are very superficially on the skin, we can actually take care of them with topical treatments that will clearly remove these lesions without leaving scars regularly. And that is a great advantage over waiting for a longer period of time until then a lesion appears that needs to be cut out, which always results in a scar. So the problem that we face is how do we get patients to come to see us early on when they still have superficial lesions that can be taken care of with topical treatments without leaving scars. We believe the answer lies in education of people about sun damage, about early changes in skin cancer development, and also to educate our other colleagues, general practitioners, other specialties, that they recognize evolving skin cancer at an early stage where it can still be taken care of without leaving scars. The question is, how do we properly get GPs and other colleagues to recognize skin cancer and to recognize what paths to take in the treatment of it? Now, the main distinction that needs to be made is a skin change thick? Is it potentially invasive? Could it be a cancer that later on would maybe spread to other parts of the body and could become a vital threat to the patient? So whenever a skin change is thick, is palpable, whenever there is a bump while feeling it, that is a lesion that merits a biopsy in order to properly establish the diagnosis, which means to decide whether it's a lesion within the skin that can be taken care of with topical treatments, or whether it's a lesion that penetrates into the skin and that needs to be treated surgically. It's always important for us to look at the patient as a person in total, so not just at the skin in an isolated way, but we try to take into consideration the age of the patient, the physical ability and the intellectual capability of the patient, how complex a treatment he can conduct himself or herself, or how much we need to take care of the patient for him. So one of the major decisions in the beginning is, should we use a patient-directed treatment or should we use a physician-directed treatment, which will allow better control but which will provide a bit more time with the physician for the patient. So on the side of physician-directed treatments, you have cryotherapy, which means freezing of individual lesions. We have the potential to shave or curette small lesions right away in our office. We can use photodynamic therapy to treat larger fields of the face and or other sun-exposed areas. We can do radiotherapy with very superficial X-rays to take care of large areas of sun-damaged skin as well. And then we switch to patient-directed treatments, which consist in the repeat application of topical agents that typically induce a certain amount of inflammation. And subsequently, when the inflammation goes away, we have a resolution of the skin changes. We usually try to explain actinic keratosis as a change that is malignant with the individual cell. That means it's skin cancer by definition, but we try to compare it to a very early change. So if you want to compare it to a car, we can say the car slightly malfunctions because there may be a bit of a rattle, but the car still runs smoothly. So when you take care of that rattle, the car will keep running smoothly and there is no danger to the car. And when we translate that example to patients, we try to tell them that formally they have a form of skin cancer, but that skin cancer is a technical problem that can usually be taken care of quite well, and that very rarely, except for high-risk circumstances and several unfortunate conditions, never ends up being a vital threat to the patient. So we reassure our patients that what they have is a problem that needs to be addressed, but on the other hand, it's not a problem that will end up killing them. And that, I think, is very important to reassure patients when you talk about skin cancer, as cancer itself has a very bad reputation and triggers a lot of fear in patients when they're confronted with the diagnosis of cancer in general. I think it's probably the focus on early recognition and understanding of the factors driving skin cancer that could get specialists, GPs, and patient organizations to communicate on the same level. Because a lot of effect can be achieved with proper prevention. That means having a modest amount of sun damage will result in much less skin cancer. So dermatologists try to educate their patients to have proper behavior, staying out of the sun from 11 a.m. to 3 p.m., using clothing to cover up large areas of the skin, and using sunscreen on a regular basis. This message of sun protection based on the 3 pillars of behavior, clothing, and sunscreen should be carried out to the larger population in general, and that is a channel of GPs that can be used, and also patient organizations could be very helpful in that respect.